So in the previous morning session, many of the presenters talked that many countries in the Asia-Pacific regions aim for malaria-free in 2030, including Thailand. But in Thailand, cases were dramatically reduced over 2 decades. Starting from that, however, starting from the 2021, in recent years, malaria cases has almost tripled increases with the resurgence because of the influx of mobile and migrant populations along the Thai-Myanmar border regions. And globally, in worldwide, Plasmodium virus has around 4 million cases, with a significant burden also in the Thailand-Myanmar border regions. So for the elimination goals, Plasmodium falciparum can be eliminated feasibly, but we have facing the challenges for the elimination of Plasmodium virus infection. And along the Thai-Myanmar border, there are over 700 malaria posts covered by SMRU. So those malaria posts have to achieve the early diagnosis and treatment for targeting the malaria elimination goals. So we have facing the challenges of the Plasmodium virus elimination because it's for the relapsing nature of parasite itself, and another one is for the radical cure of Plasmodium virus infection. The treatment drug was the 8-minoquinolone drugs, the primaquine and also the defenoquine. It cannot be given in the GCSPD deficient individuals, and also for those drugs can have the poor compliance and adherence problems. So according to the life cycle of Plasmodium virus infection, and likely with the Plasmodium falciparum, the liver stage parasites can stay and hide in the liver as a hypnocytes, and it can be reactivated weeks or months later and sustaining to the transmission. And it was reported that for the recurrence Plasmodium virus cases, for 80% are not due to the new infection, it is due to the relapse from those liver stage. So for the radical cure treatment, it is required to kill both blood stage and also for the liver stage parasites. So we aim to get this elimination strategy with the mustard administration. And as I mentioned before, the GCSPD deficiency has a problem for the Plasmodium virus elimination. So GCSPD helps to maintain the balance within the human red blood cells in response to the oxidative stress. So for those individuals who have the GCSPD deficiency, if they were exposed to the certain factors like the fava beans, and particularly for the medications of 8-minoquinolone drugs, which are required for the radical cure for the Plasmodium virus infection, it can lead to the serious health problems. So those 8-minoquinolone drugs can cause the oxidative damage to the red cells, and GCSPD deficient RBC cannot generate enough enzymes to protect themselves, causing the hemolysis and sometimes can cause the fatal conditions. And in the population context for those regions, the populations of around 15% have the GCSPD deficiency, and so it is the most difficult problem to get the radical cure treatment with those 8-minoquinolone drugs. And there were two 8-minoquinolone drugs, defenoquine and primaquine, but there is a difference with the defenoquine and primaquine is the duration of the steady drug administration, because we currently use the standard 14 days primaquine treatment, but for the defenoquine, it can be administered as a single dose just for 1 day. So it could be improved for the adherence of the clinical management and operational feasibility in those MDA campaigns. However, defenoquine-based MDA has not been operationally tested in the real-world settings, and GSK, the manufacturer of the defenoquine, recommended the quantitative GCSPD testing with the biosensor is mandatory before prescribing defenoquine to ensure that the patient has the normal enzyme activity of more than 70% or more than or equal 6.1. But there are some other contraindications in addition to the G6PD deficiency recommended by the GSK. The tafenoquine cannot be given in the pregnancy and lactating mother, and also individuals with psychotic problems and allergy to those drugs. So how can we manage this ineligible individuals in the MTA? And also we have explored the asexual blood-stage schizodecidal activity of tafenoquine in those MTA by comparing the submicroscopic prevalence at the baseline and also the MAN1 follow-up. So we aim the two objectives. The primary objective has those tafenoquine-based MTA tested by the point of care G6PD can be feasibly and safely implemented in the remote area settings. And another one is, as I mentioned, that the population, those are not eligible for the tafenoquine, what are the best approach for those cases to manage. And this study has been approved by the Oxford, by University of Oxford, and local authority organization committees conducted the study villages areas, and also this study has been already registered in the clinicaltrials.gov. And this is also the pilot study to assess in 3 study villages to assess the feasibility and safety of tafenoquine MTA, and we expected to expand in other regions for the Plasmodium virus elimination goal. And our study design is the single-arm pilot mustard administration study, and for the eligible populations for the age of above 6 months and non-pregnant individuals with the G6PD activity of more than or equal 6.1 and no anemia with hemoglobin more than 8, those populations can receive the single dose tafenoquine with 7.5 milligram per kg. But if the individuals who are not eligible for the tafenoquine, we offer the chloroquine prophylaxis. So our primary endpoint is to assess the feasibility by the adherence and acceptance of those MTA, and also we monitor the safety by monitoring the adverse events and hemoglobin change at T7 follow-up and MAN1 follow-up. And also we evaluated the Plasmodium virus prevalence by the microscopy and PCR results at baseline and MAN1 follow-up. And for the incidence data collection, we have tested the rapid diagnostic test from the passive surveillance throughout up to 1 year after the MTA period. So we have conducted in 3 villages and we have conducted in three villages. I have mapped in the red cycle, and those 3 study villages are located in the eastern Myanmar along the Thai-Myanmar border, and where those areas are higher for the Plasmodium virus cases before the MTA campaign. And those 3 villages for mainly Plasmodium virus incidence is between median IQR of 8.2 to 66.9 per 1,000 person year for this one. So we have implemented this study, MDA, starting from the February to April 2025 with the intensive phase and baseline and MAN1 follow-up. And for the incidence data collection, we collected up to 6 months from the malaria poses, which has already been set up at those study villages. So before the MDA administration, we have screened all the participants for the pregnancy by urine ACT test, and the most important thing is the G6PD activity. We recorded with the SD biosensor quantitative testing, and for the anemia we checked the hemoglobin by HemoQ 301, and also before the MDA we checked the malaria infection by the RDT microscopy and RNA-PCR. And also the participants who have the positive RTT or microscopy results positive, we have treated with the standard anti-malaria therapy before in addition to the MTA. So for the must-read administrations, the tafenoquine, the individuals who have eligible for the tafenoquine, we gave the tafenoquine 7.5 milligram per kg single dose. But for those who are ineligible for the tafenoquine, we gave the chloroquine prophylaxis with the monthly 3-day treatment dose. And I highlighted that we also administer the 10 milligram per kg weekly dose for total 3 months. And for this one, I will explain further in the further slides. And as I described, that we give the tafenoquine, but tafenoquine can have the gastrointestinal side effects. So to avoid these side effects, the participants were advised to eat before coming to the survey, MDA, or we provided some food before the tafenoquine administration. And for those who received the chloroquine monthly prophylaxis, we have give the treatment dose of 10 milligram per kg on first and second day and 5 milligram per kg on the third day. And for the pregnant woman who cannot also receive the tafenoquine, so we gave the chloroquine prophylaxis 2 tablets weekly for at least 3 months. And also you can see the pill cutter. So for the children who cannot administer the tablets, so we use this pill cutter and we administer with the mix with the water, and we give the prescribed dose to these children. And for the results, we can see that for those 3 villages, there were around 1,564 populations. We got this from population census before the MDA period, and for the MDA participation period, out of those, from the first 2 villages, there were around 90% coverage can get, and for the remaining villages, we can cover this around 72%. And also, we can also find that for the GCSPD less than 6.1 who are ineligible for the tafenoquine, have around 26% in overall 3 villages. And in addition to the GCSPD deficiency, there are another factors who can ineligible for the tafenoquine, so there were around 30% in all 3 villages. And we also found that before the MDA administration, we had found Plasmodium virus infection around 11% in all 3 villages. And our primary endpoint is to assess the safety and feasibility of those tafenoquine MDA. So we have found that in the children less than 5 years, they vomited after the tafenoquine. So we have found around the 17% in those children, but for the older children and adults, so we just found around 1.2% with a significant p-value of less than 0.001. And also we found that another advance of dizziness. So after the individuals who have dizziness after taking the tafenoquine is around 5.1%, but for those chloroquine, and you can see that for those chloroquine M groups, the dizziness side effects were more than the tafenoquine. And also, I have described that we have, for the chloroquine prophylaxis, we have administered the monthly prophylaxis and weekly prophylaxis. So for those weekly prophylaxis, we have changed in the remaining villages, because in the first 2 villages, after taking the chloroquine prophylaxis, we have found that many of those individuals have dizziness complaints. So during the MDA campaign, for the remaining village, we changed the chloroquine monthly prophylaxis to the weekly prophylaxis. And also in all 3 villages in general, we found that chloroquine-related dizziness have reported in more than 20% for those monthly chloroquine prophylaxis. And another important thing related with the defenoquine drug administration is the hemoglobin drop. So we follow up on day 3 and day 7 for the hemoglobin check, and we have found that median hemoglobin decreased around 12.5% in participants who received the defenoquine, but the individuals who didn't receive the defenoquine had not much hemoglobin drop. But all of the participants of the hemoglobin levels returned to baseline at the month 1 follow-up. And another report of the safety and tolerability, another report is the serious adverse events. So we have reported 6 total serious adverse events, including the 2 expired cases, but we have proof that none of them were likely related to the study drugs. And we reported a case of 1 pregnancy. For the month 1 follow-up, we have also tested again for the urine ACG test, and this case was positive for the urine ACG test at the month 1 follow-up. But she delivered the baby on last November 2025 without the congenital abnormalities and without the maternal complications. But we still continue this baby for the developmental follow-up and the consequences until the 1 year of age. And for the blood disorders, we didn't find any blood transfusion related to the hemolysis or defenoquine related adverse events. And for the safety measures to minimize the participant risks and to ensure these adverse events for the prompt management, so during the MDA period, from the baseline MDA period to the month 1 follow-up, medical team led by the doctor present standby at each villages, and we thoroughly explain the side effects of the drugs, and if it happens some of the side effects, so they can come immediately to the clinics, and we can manage immediate medical intervention. And if we cannot manage at the site, we can refer to our SMRU clinic or the Thai hospital for especially for the severe anemia and the massive hemolysis. And in addition to the primary endpoints, we have the secondary endpoints for data collection to assess the incidence of the plasmodium virus infection. And we have found that the incidence is dramatically reduced during the MDA period and month 1 follow-up. But you can see in the pointer. But in May 2025, in those 3 villages, there was a conflict and the displacement of the population, so we cannot collect the incidence data precisely. The incidence, and starting from this period, we have found that the incidence is rebound, and we didn't exactly know it was likely due to the end conflict or some other reasons. But for the PCR results, it is still pending to evaluate the impact of the defenoquine on the submicroscopic parasitemia, because those are the preliminary results, and we cannot get the complete data analysis for our study. So our conclusion is that according to the preliminary results, defenoquine-based MDA was feasible and well tolerated in the remote area settings, and the safety can be acceptable with no serious adverse events related to the study medications. And our preliminary data show a marked reduction in the PV incidence at 1 month post-MDA. that we have to clarify that molecular results and long-term follow-up for the full impact on the transmission and the relapse. So our future skill is to address the operational challenges, particularly how to manage the tafenoquine ineligible individuals. And in addition to this, we also have the 2 ongoing studies for the radical cure of plasmodium fibers using the tafenoquine. And one study is the multi-site project to optimize the high-dose tafenoquine compared to the current dose. And this is conducted in the 4 Southeast Asia countries: Laos, Thailand, including our SMIU in Cambodia and Vietnam. And another study is implemented, an ongoing implementation in the SMIU. This was about to evaluate the efficacy of the tafenoquine in combination with the ACT groups of drugs for the radical cure of fiber study. So I would like to thankful for the community members who have participated in our tafenoquine MDA study, and I'm also delightful to my study team members and our colleagues to achieve this study successfully and completely. And I'm also thankful to the JITMM to allow me to participate and to present in this session. Thank you.